So, welcome to another session of OSCE of COS. And last time when I presented to us, we were case scenarios discussion. Now it's more of certain questions and answering the questions, putting certain cases, X-rays. We will not go for the diagnostic part more. So let us start with the first one. So can you see the screen now?
Yes.
Kanam, sir, Kanam.
Yeah. Now you on the screen you can see a photograph. Sham.
Yes, sir.
Sham is there?
Yes, sir. Yes, sir.
Yeah. Sham, I'll be asking you a question. Who are there from Amrita, Sham, other than you?
Sir, myself, Aravind, Karthik, Naomi, and
All right.
yes.
Okay, fine. So, you have seen the photograph here, right?
Yes, sir.
Can you just describe this?
Sir, the image shows, sir, ankle joint with the ankle and plantar flexion, and there is a deep medial crease seen. Okay, yes. This is a cabo varus deformity noted, sir.
Okay, don't commit now. We'll see the other photographs.
Yes, sir.
Okay, see the next. Okay, now you are seeing the plantar side.
Yes, sir.
Now describe this.
The medial crease extends almost all through the entire plantar aspect into the lateral border of the foot, and deep posterior crease is also noted. And there is the medial malleolus is not visible clearly. Sir.
All right. So is it the usual thing that you see, or is it a little abnormal?
No, sir. It is
So when you are having a congenital virus, you see certain clinical features, and if you look at this picture, is it the same or is it different?
no, sir. It is different, sir. Because usually we don't see the medial crease to be this long.
Yeah. Naomi?
Yes, sir.
What is the difference from the normal one that you see, usual one that we see?
So that here that is a deep posteromedial crease, sir.
Okay, so that you have mentioned. Okay, now next slide. Okay, now you see from the doors. What is the difference? What all things are here?
The great toe is small, sir, compared to the other toes.
Yeah, great toe is small. And what has happened to the great toe?
It is dorsiflexed.
It is dorsiflexed. What is seen on the lateral side, just below the lateral malleolus? What are you seeing here?
Small heels.
No. Here, there is a. What is here? The skin is wrinkled, right?
Yes, sir.
And you see a little bit of fat here, irregular fat here. Okay.
Yes, sir.
Now what is here? Lateral border.
Crease is also seen. A deep crease.
Yeah, the crease has come to the lateral side, right?
Yes, sir.
Okay. Now you look at what all things you see here. Now this is the lateral border of the foot. Okay.
Yes, sir.
And this is the calf muscle. Okay. So what do you see here?
There is calf muscle atrophy is seen.
Atrophy, sir.
Soft tissue atrophy here seen, right? And not only soft tissue atrophy, the muscle is here only, right?
Calf muscle, yes, sir.
But the rest of it is tender. Yeah, calf muscle is atrophic.
Yes, sir.
This is tendinoculus actually. And what has happened to the lateral border? It's also concave.
Yes,
Isn't
sir.
it? It is also concave. unlike the medialis. So there is a cavus here. So there is a problem of the connection is unstable. Can you hear?
Yes, sir.
Am I audible? Okay. So there is a situation where the forefoot, the whole forefoot from the lateral side and to the medial side is dropped. What is that deformity known as?
Smashed heel.
Mhm. That is called plantaris deformity. Okay, that is plantaris deformity. So, Sham, can you just
Yes, sir.
sorry. So we have seen the photograph from the dorsum. We have seen from the plantar side. We have seen from the lateral side. We have seen. Now you describe all those findings that you have in this particular case. Number one.
A deep posteromedial crease, sir,
There
which
is
is extending to the medial as well as lateral side.
okay. Then next,
Then
what you are seeing?
uh,
Okay. Next.
a big toe which is dorsiflexed.
Yes.
Wrinkled skin on the lateral aspect,
Yes.
inferior to the malleolus, and
there is the
also atrophy of the cardiac muscle.
trees going through the lateral side.
Lateral side.
What deformity?
Plantaris
Deformity.
Plantaris deformity.
That's a long tendocles with atrophic calf muscles, right? So combining all these things is a feature of a type of clubfoot. So I just enumerated these things. This is a small foot, dorsiflex big toe, long tendocles, fibrous to plantar fascia, and plantaris deformity as a result of fibrosis of plantar fascia. And there is cavus, which is normally you see this cavus in the medial side. This cavus is an increased height of the medial longitudinal arch. Here you see the lateral longitudinal arch also is curved. So this is a feature of a type of clubfoot which is called
Atypical clubfoot.
atypical clubfoot.
Clubfoot.
Atypical clubfoot. So these are the features of atypical clubfoot. Okay. So why it is important? We should recognize this, and why it is important. What is the importance of identifying this? Because there is a different regime of treatment. Can Naomi tell me what tell us, what is the difference in the regime that we use from the, what is the normal regime that we use for clubfoot?
Normal is the Ponseti technique,
We
sir.
use Ponseti
We-
technique. So can you use the same Ponseti technique here?
No, sir.
No. So what is the difference?
Let me say.
Sham? Karthik?
Alakata regime.
No. I think none of you know about that. So just because we want to save time, right? So the regime is, what is the usual thing that we do? The first step in treating a Ponseti is elevate the first rib, right? So
Yes,
correct the cavus deformity. That's the first thing that you do. That's the first plaster.
മറ്റേ
Then you
മുകളിൽ ഒരു പേഷ്യന്റ് എന്നാ മറ്റേ പഴയ പേഷ്യന്റാ കിടക്കുന്നത്.
then you gradually abduct the foot. You will not pronate the foot, and your thumb will be, when you manipulate the foot, the thumb is placed in normal Ponsetis. You place the
thumb over the head of talus.
Yeah, over the head of talus, just in front of the lateral malleolus. Okay, these are all different, and these are all different when you come to the atypical clubfoot. What we do is we use both the thumb to dorsiflex first, to correct the plantaris deformity first. That's what it is. Not the first metatarsal alone. The fourth, fifth metatarsal is also dorsiflexed. So can you see my hand now?
Yes, sir.
Yeah. You will hold the dorsum of the hand with your fingers and the thumb on the first and the fifth metatarsal and try to elevate it. And the fulcrum is the mid-tarsal joint. When you are using it normal Ponseti's technique, you will be trying to, your pressure point is head of the talus. So that's the first difference here. So you correct the forefoot drop and not the first metatarsal drop, or otherwise correct the plantaris first. Plantaris deformity first. Then you gradually abduct. And then abduction process starts the same. Now the Ponseti's regime goes. So the first step is different. You understood? That is the first difference. The second difference is, see, when you try to abduct the foot, using the thumb on the head of the head of the talus, you abduct the forefoot. What is the level in which you want to reach, Anupam? What is your goal to reach when you are abducting the foot?
Sir, in atypical club foot, abduction should be up to.
No, I'm talking about a normal one.
Normal one, 60 degrees, sir. 70.
Yeah, 60 to 70 degrees of abduction. Yeah, but this is not possible in a typical club foot. So our idea is to reach around 30. So once you reach 30 degrees, it's fine. Okay, that is number one. The dorsiflexion, what is the level of dorsiflexion that you want in a normal club foot in Ponseti's regime? What is the level in which you want to reach that?
20 degrees.
30 degrees.
The level of dorsiflexion of the angle.
30 degrees.
30 degrees you should reach. Here you won't reach it. So the neutral will be fine. Then what is the third criteria on which you say that you have corrected it?
Varus.
So one is the abduction, second is the dorsiflexion. What is the third?
Varus correction.
No, these are simple things. Heel varus. What should happen to the heel varus?
Normally heel varus we correct to 40 degrees, sir. But in atypical we correct it to neutral.
No, forget about atypical. Forget about atypical. I'm asking you the normal scenario. What do you expect?
For 40 degrees, sir. Corrected up to 40 degrees.
No. How can you have the varus correction to 40 degrees? Heel will tilt up to that level. Heel should be neutral or in abduction. That is all. Right.
Okay, sir.
A minimal varus is all that you can achieve. So there are three criteria when you say that you achieved that in a normal Ponseti's regime, that you have achieved correction. What are those three? Naomi, repeat. For everyone's benefit, because this question was asked in the exam. So you should know this.
Abduction 60 degree.
Yes.
Dorsiflexion of 30 degrees and heel varus to neutral or abduction. 30 degrees.
And keeping varus should not be there.
Well,
yes, heel should not be there, not 30 degrees. Varus should not be there.
Should not be there.
It should be either valgus or neutral. Okay.
Sir.
So now, when will you do tenotomy?
So when we do not achieve this.
So when the heel is not in varus.
Heel is not in varus. Criteria for doing tenotomy. All are different in atypical. That is why I am asking this. What is usual normal and what is the difference in atypical club foot? You have to reach the level of abduction 60 degrees. That is prerequisite one. The heel should not be in varus. And you reach a dorsiflexion level up to neutral or 10 degrees. And these are the three indications at which you will do a tenotomy. If you have not achieved this, you further abduct, which is not the fifth plaster. Usually we can achieve this correction which we are talking about by plasters. But this will not, if it is not happening, then you have to continue plastering further. You understood? So here, when you are trying to do in a typical club foot, your goal of abduction is 30 degrees. dorsiflexion neutral, then heel may be in varus. Even in that varus situation, you are justified in doing a tenotomy. You understood? So there is a difference.
Yes, sir.
Then, okay, this is the difference. This is something which you should understand. Okay, then we are giving brace. And the brace, what is the usual brace that we give? What is that brace known as? Anupam, how do you prescribe that?
Foot
Sir, foot abduction brace, sir.
Yeah, foot abduction orthosis, FAO.
Yes,
That's what we
FAO.
call it. Okay. And here there is a bar. And the foot abduction that you have, what is the abduction? 60 degree.
60 degree.
But when you are using in this one, your reach is only 30 degrees. So you have to keep that, prepare this for that particular purpose, that particular angle. Okay. And you have to, the chance of recurrence is very, very high. So we examine this patient to see whether it's recurring or not. And since the foot is small, most often the plaster will slip off.
Yes, sir.
So slipping of plaster, and next day you put the plaster, and next day patient coming with plaster in the hand. That's the usual thing in atypical club foot. Okay, so we understood the difference between atypical club foot and normal club foot. Yes or no?
Yes, sir.
Yeah. So it's equally important that you have the problem of you have very little idea about the normal club foot. What is the regime? That first you should learn, because it's a fundamental thing in the exam. You cannot escape from that. Okay. So this we have already mentioned all these things. This is what I was trying to tell. So I think if anybody want to ask a question now, you can ask. A point which is not clear, you can ask him. Any student in this group? Because I know there are institutions where this is, you may not have it may not be routine to have such cases. So you may not have seen much of cases. Okay, so then we can go to the next case. Okay, this is 17-year-old male, injury of the elbow 3 years back, was treated by massage, and now complains of pain while playing and lifting weights. And this is the picture. Yes, anybody can make. I need not ask questions. I pick up persons. Anybody in the group can answer this question. What is this condition? Diagnosis. It must be interactive rather. We can go very fast.
Dislocated radial head, sir. Chronically dislocated radial head.
Chronically dislocated radial head. Where is the radial head?
Neglected lateral
Anybody else?
condyle.
Huh? Yeah. You're right.
Neglected lateral
condyle fracture.
Yeah, it is neglected. Is it united or ununited?
Non-united.
Non-united.
Yeah, these 3 years and ununited lateral fracture patient coming with that. Okay, so what will you do now? Pradhaman, Pradhap? Yeah, okay. Right, what will you do now? He has got pain while playing and lifting weight. And this is the X-ray.
Open reduction, internal fixation, sir.
Open reduction and internal fixation. You will correct the deformity and then do it, or you just fix it in situ. I think that we cannot go in detail about all those things. You go back, and this was kept for our MS exam this year. And I'm asking the questions that Exchange asked to the student. Okay. So if you get a lateral condyle fracture, what are the problems that you can have?
Chandrababu, sir.
Yeah.
Can I ask you? Is
Yeah,
everyone happy?
Right.
Everyone happy with this radiograph? Or they want any?
Yeah, you just yes. Dr. Pradhaman is asking you a question. Are you happy with this X-ray?
the lateral film also.
One more view is required.
Yeah. Yes, Pradhan, continue.
Okay.
Even ulna it's a fracture of
Look at the medial side as well. Distal humerus. Can you see that? Just above that, there's a traction injury. Where? Yeah. That's right. That is something attached there, isn't it? Some soft tissue attached there. So anybody can.
medial collateral ligament.
Exactly. Yes. So there's a both injuries are associated. It's a just giving a clue. Sir, you got a lateral or a CT?
No, only this is sir. Lateral is not.
I will keep quiet now. So you continue. I just gave a lead.
Yeah. So the questions that were asked is, in such a scenario, what is the problem that patient can have? So unrelated fracture, lateral condyle fracture, what are the likely problems that patient can have?
Chronic pain while doing daily routine activities.
Yeah. Right.
Then decrease power of the on that side.
Yes. Then
Tardial palsy.
they can develop a valgus deformity and tardial palsy. Right. So these are all problems that you can develop on long term. This patient anyway doesn't have a valgus deformity because he is 17-year-old and deformity, the growth in the elbow. We will not go into that areas. Okay. So the treatment, there is something called Flink's criteria when you want to fix a fracture of non-union like this. What are those criteria? Anybody can tell me? If you are going to fix this in situ, there are criteria. There should be a large metaphyseal fragment, then an open epiphysis, and a gap which is not very big. So this type of cases can be treated by fixing in situ. That's the way it is to prevent, give a stability which reduce pain while lifting weights and playing. Okay, so that is the classification also was asked. And rotated. There are 3 types possible. So this question was also asked to the student. Okay, Pradhaman, anything you want to add to this? We are going very fast on.
Yeah, that's right. Yeah, no, sir, as I mentioned earlier, I'm not very happy with the radiograph. I just want to get a lateral and if possible a CT because it's already 3 years down the line. What we need to see is a cortical structure of the whatever bone is remaining. And I just want to know whether there's a capitula is involved. Capitula is involved, then probably you will have a bigger chunk of bone, which will facilitate the fixation and healing. And more than what you see on the X-ray, just a bony fragment, there are a lot of structures attached there, especially the ligaments and the part of the lateral mass of the forearm. So it's very important that what's going to happen is he will lose the pronation supination. Well, power grip, power sort of thing, like using a screwdriver and sort of thing. So it's very important that as he become adult, he need to have a proper functioning of that part of the bone.
Okay, thank you. So further addition to this, there is some value addition to this discussion. And I'm very happy that Pradhaman is also there and we want the senior people to contribute like that. So we need more of investigations and you have to look into much more details on this. Okay. So the other question that was asked was, when you are having a valgus injury, you get medial epicondyle avulsion and you get lateral condyle fracture. See, when you have, which is a mechanism that produces this injury, that is number one. Why medial epicondyle is isolated, and here you have lateral condyle, but medial condyle is not very common. You get medial epicondylar fractures. Read about that. If we go into discussions on this, it will be difficult for you. We cannot finish off this because of the muscle attachment and the pattern of injury and the pull. This is far. So the reason out this answer for these questions. Now there is another case. Now you look at this X-ray. Keep diagnosis. This was also kept for last exam. Naomi.
So this
Monteggia.
Monteggia.
dislocated radial head.
Dislocated head. Okay. Anything else?
Ulnar fracture.
Malunited ulnar.
No, this is an acute injury. Right.
Yes, sir, with an ulnar, proximal ulnar fracture. Yes, sir.
That is a proximal ulnar. Is it the, what is that fracture when you have a proximal ulnar and dislocated radial head? What is known as?
Monteggia.
Yeah, is it Monteggia?
Yes.
Can you call this as Monteggia? Yes, you can. So we should also know something about Monteggia equivalence. This was also asked last question. You know, these questions which I'm showing, you know, these are was the usual exam questions. So you should be able to answer these questions. Okay. So why do you say that's what structure? No, this. What is this?
Lateral epicondyle.
This is lateral epicondyle. This big is lateral epicondyle. Nobody is talking, no? Not big questions are asked. Which is the structure in the X-ray? Karthik?
Not clear, sir.
Huh? Don't see.
That is the capital. Sorry, that is the capital, sir.
There is a shadow of the capital. There is a shadow of the capital. Where capital articulate with which structure?
Radial head.
Radial head. So if you draw a line along the radial shaft, what is that line known as?
Radiocapitular line.
Yeah, what is that line known as? Somebody's name is there?
Knowledge line.
Huh? That line is called McLaughlin's line. You have to read all those things. These are fundamental things in orthopedics. There is no meaning in going beyond the finer things here. So what is this line? This line should bisect the capitulum in all positions of the elbow, whether you are in flexion, extension, whatever position, it should. It is very, very important that you know this, because there are many situations where subluxations are not detected, and then it progresses in plaster, and when the patient comes with a restriction of movement, and I know at least 2 cases which has gone for consumer court because you miss it. So it's very important that you should draw this line and see that this line is perfectly cutting through the capitulum. See, this is the capitular shadow, and you see the head is anterior. Okay, and anyway, for the purpose of to continue this, this is not the level in which you get the Monteggia fracture, right? It is in the lower at this level, below the level of the heart. So this is almost at the very high level. A proximal ulnar fracture with anterior dislocation of the radial head is known as, described by Hume, and this fracture is termed as Hume's fracture, H-U-M-E, Hume's fracture. Okay, but at least it's a Monteggia. That part at least you should know. You should know what about McLaughlin's line, how to draw that, and what is the significance of that. That part you should know. Okay. Okay, so the diagnosis we have. Then we also, this question was, and I just put all those things because this was just happened 1 month back. The questions were asked by the externals to our students. What is Monteggia equivalent? So if you have, these are the 3 situations. You have to read this topic. isolated radial head dislocation, and sometimes there is then associated with a radial neck fracture. And the third one is usually you don't have a fracture at lower third in the in the radius. I'm sorry, I'm sorry, the fracture is happening in the radius at a more proximal level than ulna. It is not at the same level. So at a higher level, imagine the fracture is the radius is at a higher level and ulna at a lower level. That's not a common fracture that we find. So these are the three conditions which are described as Monteggia equivalence. This question was also asked. Pradhavan, anything else you want to add to this or just ask them?
Yeah, sir. The Hume's fracture is a very basic thing.
Yeah, see, that is why
you guys taught me. You guys taught me in 1986. So I just remembering that.
Yeah, this is the problem which happens in the exam. That we should understand. So that is why I have put all these cases which are kept for exams. Yeah. So these are always asked to the MS students. They should understand this, and they should also go into depth to understand. These are basics.
Yeah, sir. Can I add a comment as well? On that X-ray you put, the lateral looks very innocent, but if you look at the AP, it's a definite plastic deformation sort of thing. You can see the green stick, but more than that, it's a plastic deformation which needs to be corrected. And also, if you look at there's a definite feature of avulsion of the ulnar collateral ligament there from the proximal side.
Right.
Yeah.
Right.
So that adds up. It's a very significant injury.
Right. It's a very significant injury. Okay. So when okay. So next. Okay. Yes. Diagnosis. Quick. I don't know. Naomi, what is it? Cham.
The posteromedial.
Please describe what you see here.
Bowing of the
tibial bowing.
Tibia bowing is there.
Posterior angulation.
Yeah.
Rickets.
Tibial bowing. When you are seeing from the lateral, you can see only that, right?
Yes, sir.
Okay, right. Now this is the X-ray. Now what do you think it is? You can see the AP and lateral view.
Could be rickets.
To describe the deformity first before you go to the etiological part.
Yes, there is a lateral bowing of both the tibia and fibula, and lateral and post.
Is it lateral?
No, sir.
Look at the here.
No, sir.
AP view. In which direction is it gone?
Medial, sir. Medial
so medial and
posterior.
In this view.
Posterior, sir.
So what is it? So what is the deformity known as?
Posteromedial bowing.
Posteromedial bowing of tibia.
Somebody is talking, but your voice is feeble and we can't.
Posteromedial bowing, sir. Posteromedial.
Yeah, it is posteromedial, congenital posteromedial bowing of the tibia. Right. It is very, very common thing that you can get. This patient actually was kept for the exam, MS exam, physical exam, not the one last one. So this is a common case which is kept for your exam. So diagnosis congenital posteromedial bowing of the tibia. What is the relevance of this? Pavan has answered that question. Am I right?
Yes.
Yeah. Tell me, Pavan, what is it? When you see such a case, what you are going to communicate to the parents about this?
Usually,
you are going to be in trouble?
looking it will like no, sir. Usually, no treatment is required. It will get corrected with time.
it's not very like that point that we have, which usually end up in pseudoarthrosis, right? So this will get automatically corrected. Okay. See. So what is the natural history to automatically corrected? What treatment will you give on?
So usually treatment is required, but we can ask for some stretching
Okay.
exercises.
Yeah, now we look at that. Suppose your newborn is coming. What will be the position of the foot? The newborn is bald. It is a congenital deformity, and with this deformity, the newborn is bald. What will be the What will be the position of the foot in this?
It will be calcaneovalgus.
It is calcaneo. So that is calcaneovalgus deformity. Patient comes in. So, do you think that such a plaster is needed in such situation?
No, sir.
No, to stretch the soft tissues, you can manipulate and ask the mother to manipulate and correct. Plaster is not needed. Even without plaster, you can correct it. You can see what has happened over 4 years' time. So this deformity has straightened out, and you can see the body, right? So this is what happens. But what is the problem, Pawan? There is a problem in this. It can straighten out, but there will be a problem. What is that problem? Anybody? This is the problem. What is the problem that you see?
Shorten.
Lengthening.
The discrepancy.
Yeah, there is shortening. So there is shortening. That is the problem. How much of shortening will happen? Mother asked how much of shortening is expected in this case. What will be the answer? Maximum shortening that is around 4 to 5 centimeters. So sometimes it needs Elizarov corrections. Or what is the other option, Naomi? Say 4 centimeters shortening. What is the other option? You can shorten the normal side. That's also another option. Okay, to equalize the length. So what is important here is, this is again an exam question for you. I'm sure those from Amrita should know this, because these patients are all around. At any time you can have them. Okay, so to the other exams also, this OSCE also, you should know about it. So it's very important that you should know this. Okay, right. I think anterolateral bowing was discussed by Cherian Kovu. Am I right? Okay, right. This is different from anterolateral bowing. Okay, right. Yes. Diagnosis.
Sir, there is a genuine varus deformity which is occurring, and
You look at the X-ray and then finally, reach the diagnosis. And not just deformity alone, we can have a number of conditions. Okay. So looking at the X-ray, what do you think it is?
Sir, rickets, sir, probably.
Splaying of the metaphysis.
Yeah, spraying of the metaphysis. Splaying of the metaphysis.
Yeah, you discussed the radiological findings in this section. Sam. John C. No, why can't you discuss this? You are seeing this, and why can't you explain this? What you are seeing here in the on the exam?
The metaphyseal flame is there, and
Metaphyseal flame is there. What else?
growth plate widening.
Widening of growth plate.
Widening of the growth plate.
Yes.
Oh, sorry, sir.
Spur sign is there. Yes. You look at the trabeculations, they are coarse, and you look at the amount of deformity that is happening in the metaphyseal region in both tibia and femur. So it's not only epiphysis, it is going into the metaphysis also. Yeah. So all these are features of what?
Rickets.
Rickets.
sir.
Now this is what is a little zoom picture here. You can see the metaphyseal widening. Then the wide physis also. Why there is physis widening? What is the reason for that? What is the reason for that? And you find the line is irregular rather, and the density here in the normal situation you find more dense area here. And why these are like this? Yes, Anupam. Anybody? So what is happening? What is
mineralization? We just should read the physis, isn't it? The structure of the physis and the mineralization, all this.
Many things are exposed here to all the students who are listening here. We are not talking high step orthopedics at all. We are talking the fundamental basics of orthopedics. So we have to understand that you have to make these areas very, very clear. See, the structure of the physis, should know about the mineralization and what is how mineralization happens and what is rickets. What is rickets, Anupam? Can you define that? Naomi?
It is a defect in the mineralization of the
defect of the mineralization in normally forming osteo. Right. That is a classical thing.
Yes.
Yeah. But what is osteoporosis? What is the difference between osteoporosis and osteomalacia? What is osteomalacia anyway?
Unmineralized or poorly mineralized osteoid.
That's what is the difference between rickets and osteomalacia?
Defective mineralization is keratally mature.
Yeah.
After the closure of
physis.
In children you call this as rickets, and in adults the same scenario you call this as osteomalacia. Then what is osteoporosis and osteomalacia difference?
So a quantitative defect in the bone is osteoporosis.
When you say that, what do you mean really?
Normal mineralization in a defective matrix.
Yeah, both minerals and matrix are not formed well when there is osteoporosis. It is defect in the bone mass per unit volume. That's the definition. You should learn all those definitions and you should be able to answer it very fast. Right. So here the zone, the epiphyseal plate, we have got 5 zones actually. You should learn that. Germinal zone, proliferative zone, maturation zone, ossification zone, and calcification zone, and then remodels. So what is happening is this mineralization zone. See, then epiphyseal, the germinal zone is okay, proliferation is okay, then it becomes maturation zone, and then it should get calcified. And this calcification process becomes defective. As a result, what happens? There is a widening of the non-calcified epiphyseal plate, and that's why the epiphyseal plate is wide. And here you see the calcification which is happening is not normally. This is because this mineralization in this area is also defective. And the metaphysis, because of the traction of the muscles and all those things, it gets played out. Periosteum will also form from bone, which is irregular. And the mineralization in these areas also irregular, so the trabeculations are coarse. So the bone is weak. And as a result, what happens? There will be a deformity which is developing in the bone. And this is the reason why you get these deformities. Okay. So I think we'll stop at this point regarding the pathology. If you read the pathology of this. Okay. So this is rickets in non the RICKET rickets. If you write, if you just remember this, some of these points will come. It's not easy to remember, but some of the points may come to you. Somebody asking you what are the radiological features of rickets. So we talked about spurring, we talked about the cupping and spraying of the metaphyses. Then the epiphyseal plate changes, all those things. And the common sites where you get these changes are the areas where it grows fast. Okay, so then we should know three types of rickets. One is the deficiency ricket because of the dietary change or the formation absorption of the calcium and vitamin D is not happening properly. That's dietary or celiac. So that's called deficiency rickets. Okay, the second one is dependent rickets. So there are two types. There is a problem, congenital problem here. There are VDRR, vitamin D, dependent rickets 1 and 2. I think you should read about that. We'll not go into the details of it. And here there is a terminal end organ resistance. Here everything is fine of metabolism, but it cannot act on the end organs. And this is VDDR type 2. And the common feature is alopecia. And then the third part is the resistant rickets. And resistant rickets is usually because of the phosphate level loss. And so it's called hypophosphatemic rickets. And it's usually related to other syndromes like renal tubular defect, where you get aminoaciduria, glycosuria, proteinuria, and then it forms certain syndromes. Levy syndrome, Fanconi syndrome. Read about that. But understand DDR. If you remember this DDR, the types of rickets you remember: the deficiency, dependent, and resistant. Okay, the treatment becomes different in all these three situations. And this is one chart which is there in Nelson's Paediatrics book. This is if you just understand this, you can easily make diagnosis here. So you have the say slide which is hazy. You can make that. So radiological and clinical features of rickets. Okay, you look at the calcium phosphate and alkaline phosphatase level; they are normal. Okay. Now think about a condition, not rickets. So that is a metaphyseal dysplasia, SMID type of metaphyseal dysplasia. But when you look at alkaline phosphatase is raised, then you have to look at the calcium, you have to look at the phosphate. And if the alkaline phosphatase is raised, then normal calcium, you can see the chart here, the normal calcium of low phosphates. You have the dietary type, then very low level, when it comes to this level, it is hypophosphatic, renal tubular problems here. And the treatment is phosphate replacement. And when you come to the low part, there are two types. One is dietary and the other is the dependent rickets, and VDDR1 and VDDR2. I think you should read, and the estimation of vitamin D in different levels, D2 and D3, will give you an idea if you are suspecting VDR1 or VDR2. You will have the knowledge, but it will not act. So the blood will be a little difficult topic. So you have to understand the metabolism of calcium and vitamin D. Okay, this is the same patient. After the treatment, you can see how it has changed. Okay, it was deficient rickets. You can see everything has come back. The epiphyseal. This is the hard line which I was talking about. You can see the epiphyseal plate has closed. Here that widening has disappeared, and you can see the sclerosis here, which is the normal mineralization that is happening. And this patient had vitamin D treatment. Usually, in a deficient rickets, what you do is you give 6 lakhs of units. That is 60,000 units, 10 doses. That means 6 lakhs. And that is a loading dose. and that loading loss brings the alkaline phosphatase level down, and you will see the changes happening very fast. But you continue with vitamin D about 400 to 800 international unit, and calcium, that will continue, and it will turning normal. Okay. I think Srinivas is up now.
And then, sir?
Samaya.
Illa, sir.
Yeah, sir. Yeah, I'm there. We can have one more case, sir. It's only 9.
Yeah, because after some time, the constellation.
Yeah. So maybe last case, sir. This is the last case you can.
One more case.
Yes.
What's important? Yeah. What I want to tell all these people who are attending this is we don't do anything extra or postgraduate level in this. You have to go back and read about it because the answers that we are getting is not acceptable. So I think we should focus on these areas much more. Okay. Yes, this is a simple thing. What is the diagnosis here?
Capital femoral.
Left caprifemoral epiphysis. Okay. What is slipping here?
So, metaphysis.
So what is the direction of slip?
Anterosuperior. Anterosuperior. The metaphysis moves anterosuperior.
Moving out of the physis, right? So the head is in position, but the metaphysis is going on. And what is the deformity that we get out of it?
Like external rotation.
And external rotation will be more pronounced than the deviation. I think you remember the axis deviation. What is the expression of me?
Sir, I didn't hear, sir.
What is axis deviation?
So axis deviation is when the hip is flexed. There will be an external rotation. I mean, normally it has to point towards the knee has to point towards the opposite shoulder. What happens in axis deviation is points towards the same shoulder.
Not go to the opposite shoulder, it will go towards the midline.
Midline.
To the opposite shoulder. Okay, then. When you flex, then he will go to the ipsilateral shoulder. Okay.
Ipsilateral shoulder. Yes.
Shoulder. But the external rotation deformity also, it can happen. So this question is always asked in the exam, how to differentiate between a fixed external rotation deformity and axis deviation. Yes?
The beginning of the
Of the external flexion itself, there would be a deviation. There will be it will be pointing towards ipsilateral shoulder.
The knee will move towards the ipsilateral shoulder, but in slip, after normal flexion, then the 90, then it moves away. That's different. So classification in the duration of classification. Read that, Nami. We'll finish it up.
Classification according to the onset of symptoms. Acute is less than 3 weeks. Chronic more than 3 weeks. On acute on chronic more than 3 weeks with acute exacerbation. Next is on the ability to weight bear, which is Lauder's classification. Stable if the patient is able to weight bear with or without support, and unstable is when the patient is unable to weight bear.
Okay, right. Read that.
Slip angle classification, which is the epiphyseal diaphyseal angle difference. Mild is when it is less than 30 degree, moderate, which is 30 to 60 degree, and severe more than 60 degree.
So when you measure this and decision made towards treatment, how does this classification help you? in a mild situation of a slip, what is the way that you stabilize that slip?
In situ pinnings.
Pinnings.
In
In situ pinning.
in situ pinning. Okay, in a severe one.
Osteotomies. Osteotomies.
In a severe one. Yeah, you have to go in a different way. What do you think that is done in? Suppose it is an acute slip. What will you do? Or even a chronic scenario. What is the concept of treatment? At least you should know the method. How you approach the problem. Just described by Gans.
Curvilinear osteotomy of the
safe surgical investigation and then correcting the deformity. So there are steps there. You should remember this: safe surgical dislocation and correction of the cervical deformity. Okay. So this is how you do the measure this slip angle. You can see that the two ends of the is perpendicular. Then another line pointing to back side, and to that point that is the slip angle. Okay. Both you can do this is slip angle. And then you know how much is less than. And if it is less than 30, you can do in situ pinning. Then moderate. Pawan, if I draw a line like this, what is that line known as?
Clean line.
Clean line.
Huh?
Clean.
Okay. And what that line? What will that line do in to the epiphysis? Yeah. Trithoven's sign, you know that. Okay. So Klein's line and Trithoven's line. So if you look at here, you can see
Sham's sign.
the metaphysis. Huh? What is that?
Sham's sign. SHAM. Capaneus triangle.
Yeah, Capaneus triangle. So it will come here. The metaphysis will overlap the established shadow, but if the epiphysis comes in between. Okay. What is metaphysis? Blank steel.
The overlap of the metaphysis with the epiphysis can be seen. So, the posterior superior part of the epiphysis.
That's area. Right. You are right. So, see, we have learned the blank sign. You have learned the KK sign. You learned about the Klein's line and Trithoven sign. All this you should remember. Okay. So, this is then. What are the indications for prediction of the slip on the opposite side? Patient comes with one side, the other side can also go. Yes, somebody read that. Pawan, you can read this now.
Females younger than 10 years of age and males younger than 12 years of age. Endocrine abnormalities, obesity, and with open thyroid cartilage. Usually, bilateral slips are present in 20 to 30% of patients at initial presentation, and late slip presents with around 40% of patients.
So, the 4 points that you have, indications that you just mentioned, are indications for fixing the opposite side. So, there's every chance that you may have a slip on the opposite side. So, this is also a question very important. Okay. Then complications. Read about that.
Yes.
Contralateral osteonephrosis, you can further slip. The stool is not very common, but it can happen. Then at the level of injury, level of entry into the epiphysis, if it is done below the level of lesser trochanter, it can lead to subtrochanter fracture. This usually happens when you have multiple entry for your entry. So these are the complications. I think that is the last slide, because we will stop it here. Okay. Okay.
Okay, thank you, sir.
Yeah. Anybody want to ask any questions? You can. You're open now. Yes. Over to you.
Yes, sir. It's fine, sir. Thank you.
Sir,
How are you, sir?
Fine. That question now is not there. They're just moving on like that. Okay. The point that this presentation and discussion and the way that our students answer, we should understand the importance of discussion. Clinical presentation is to understand the gap in the knowledge. If you understand the gap in the knowledge, you should feel all the students who listen to today's class should understand where is your weakness. Go back, read, and fill that now, because these are all fundamental things that we are talking. We are not talking anything high about orthopedics in a postgraduate level. So you must read once again all these topics which we have, because these are all exam. Just these cases which I have presented here have all gone through exams. MS exam, I am telling you. Okay, fine.
Any questions?
Yes, Pradhavan, any comment?
No.
Yeah, any questions or anything?
Fine, sir. I enjoyed it.
So thank you, Chandrababu, sir. If there are no more questions from them.
Good night, sir.
Good night. And thank you, Pradhavan, sir, for joining. Make it more interactive.
Okay. Thank you.
Balu, thank you very much. Balu, you'd like to say something?
Thanks
So you
for getting
can
the technical
conclude the
things
session.
sorted
Balu.
out.
Yeah, you can conclude it.
Thank you, sir. So we'll be having our next session on elbow by Pradhavan, sir. And I hope everybody will be joining for a very interactive session. Thank you. Thank you, sir.